everybody. This is Kavish Mehta, and we are going to be going over Section 2 of the COVID-19 Mitigation Plan Report. Section 2 has to deal with testing. If our facility does not have any COVID-19 outbreak, we still have to monitor staff surveillance. This is testing staff to make sure that we are having proper temperatures, no shortness of breath, and no COVID-19 symptoms. We have to test staff during the hiring process as well. Most importantly, persons in care must be tested before admission. The goal of defining when a virus is first diagnosed means how the health department tests an area of outbreak. Once established, then the testing focuses on supporting clinical care and making sure patients who are most severe are getting taken care of. A surveillance phase will continue to take care of people who need clinical care. The surveillance system is one that will come into play as the acute situation gets under control. The facility will follow the protocol set forth by the CDC. However, the facility is not able to establish a medical method of testing residents or staff. Surveillance testing schedule of all staff, random testing of a percentage of staff, screening and testing residents and staff. We have to test residents returning from a high level of care or an outing. We have to apply statewide or county closure orders to facilities. There are new California testing guidelines, which prioritize testing for certain communities and populations. We have to test 25% of staff without COVID-19 symptoms every 7 days. We have to retest of all staff and residents at least every 7 days until no new cases are identified in 2 sequential rounds of testing. We must retest all staff and residents as soon as 1 or more COVID-19 positive residents or staff are identified. Upon confirming no new cases have been identified in those 2 sequential rounds of testing, the facility may then resume its regular surveillance testing schedule. Basically, 25% of staff every 7 days. If the facility cannot access testing to serially retest all staff, we have to prioritize testing for staff who worked in the unit who had known exposure to COVID-19, staff who are known to work at other facilities with cases of COVID-19. Exposure is basically defined as a person was within 6 feet of a person who was confirmed to have COVID-19 for at least 15 minutes without the use of a face covering on both people. New staff must be tested for COVID-19 prior to working in the facility, and staff returning from a leave of absence or a vacation will also be tested. Residents may be tested if symptoms are present or they were exposed to COVID-19. Facility will attempt to comply with recent updates to test 25% of staff every 7 days. The test will be recommended. The facility may not be able to do the testing if the facility is unable to access regular testing, has no relationship with a commercial lab, is unable to obtain physician's orders for testing, cannot afford to pay for tests, or if the staff refuses, or other reasons. Any possible resident admissions will be guided through the admissions process, must include a negative COVID-19 test, 14-day isolation process, daily screenings, and social distancing protocols. If our facility has COVID-19, the faculty may work with their local LDH to develop a testing plan for regular testing of persons in care and staff. We must retest all staff and persons in care at least every 7 days until no new cases are identified. Section 3. We're going to discuss quarantining, isolation, residents. The facility has plans to isolate or quarantine residents as needed. Who needs to be isolated? What exactly happened? When did it happen? How? Where did it happen? And until when will they be quarantined or isolated? Quarantine as persons under investigation. Residents returning from a higher level of care without known exposure but were unable to be tested prior to returning to the facility. We need to quarantine residents exposed to a person with COVID-19 and awaiting test results. We need to quarantine residents with symptoms of COVID-19 and awaiting test results. We need to quarantine residents with active COVID-19 until they are cleared to be released from isolation. Facility will take appropriate COVID-19 measures when residents return to the facility after being in another facility or at a family home. These appropriate COVID-19 measures are an increase in symptom checks of residents and staff. We have to implement isolation and quarantine if necessary. If isolation is necessary, we have to quarantine and prevent resident gatherings. CDSS will be contacted if flu, isolation, quarantine, or prevention of gathering is in place. Residents with flu and COVID-19 will not be together and will be isolated apart if possible. Residents who are asymptomatic but were exposed to a person with COVID-19 will be quarantined until a negative COVID-19 test is obtained, they are cleared by local health, or at least 14 days have passed since the most recent date of COVID-19 exposure. Residents who are symptomatic will be isolated until negative COVID-19 test is obtained, they are cleared by local health, or all of the following conditions are met. At least 1 day or 24 hours has passed since recovery. No fever. There has to be an improvement in any symptoms. And at least 10 days have passed since the symptom first appeared. For residents returning from a higher level of care, a hospital, a visit to a healthcare provider, or an outing, facility will, to the extent possible, continue to follow CDSS testing guidance. If the resident cannot be tested prior to their return to the facility will contact the licensing office if help is needed to access testing. If the resident does not receive a test result prior to their return to the facility, the resident may need to quarantine until the resident receives a negative test result or is quarantined for 14 days upon the return of the facility. Or, while quarantined, staff continues to monitor the resident for the COVID-19 symptoms. The facility will evaluate on a case-by-case basis residents returning from the hospital with a positive COVID-19 result. The facility will consider allowing a resident to return to the facility without being tested if the resident was either treated or monitored for COVID-19 and completed the period of isolation at the hospital. If the hospital or SNF treating the resident determines a resident is ready for discharge before the isolation period is completed, the facility will consult with the hospital and the local health department to determine the remaining length of isolation time required at the facility. The resident does not need to isolate longer than necessary. The facility does not need to maintain and staff the isolation area longer than necessary, only after consulting with the hospital or SNF. If the facility becomes aware of a known exposure that occurred during the visit, the licensee will notify the resident and the resident representative. We have to quarantine the resident for 14 days and get the resident tested. The facility will consider periodic surveillance testing and information gathering for For residents that regularly leave for hospital visits, dialysis treatments, emergency room visits, and other medical appointments. If resident is isolated or placed into quarantine, the facility will check the resident's general appearance every 4 hours. Essentially, we have to check the resident's temperature, oxygen saturation if possible, and respiratory rate, and breathing to determine if it's fast or labored. Facility will keep in frequent contact with the resident's healthcare provider to quickly detect deterioration in status and the need to transfer to a higher level of care. If a resident is in the facility and deemed to have recovered from a COVID-19 infection, there may be a residual cough for several days. The facility will ask resident to wear a face covering when outside their room until the resolution of the cough, and continue with physical distancing when in a group setting. The residents will be considered as the resident may not remember to wear the mask and not likely to wear a face shield either. Facility will keep other residents safe by asking them to wear a mask when they are near the recovered resident. If a resident has a positive test result, the facility will immediately contact the local health department and the resident's representative. Facility will isolate the resident in the facility or healthcare facility if directed by healthcare professional until they are determined no longer to be infectious. Cohorting. Cohorting essentially means the practice of isolating multiple individuals with laboratory confirmed COVID-19 together, or quarantining close contacts of an infected person together as a group due to limited space. Cohorting is not recommended due to the high risk of transmission from infected to uninfected individuals. If a dedicated COVID-19 positive space or unit is unavailable, residents with active COVID-19 are cohorted together. For purposes of this, we can essentially call cohorting grouping together, staying together. Single occupancy rooms may be temporarily used for double occupancy in cohort unit. Dedicated staff are scheduled to work in the cohort unit. All residents on quarantine or isolation are checked for general appearance, oxygen saturation, respiratory rate, and symptoms consistent with COVID-19 every 4 hours. Residents with a suspected respiratory or infectious illness are isolated to a single room if possible until a test confirms that a COVID-19 positive case, at which point they would be moved to a red area and then checked every 4 hours to quickly identify residents who require quarantine or transfer to a higher level of care, such as a hospital. The facility may have difficulty placing residents in a dedicated room or unit due to the space and occupancy. If a private room is available, one resident may be moved into a single space, or 2 residents can be moved into one private room. The facility will attempt to educate residents and staff on grouping isolation as follows. We can use a separate bedroom if available, or if a bedroom must be shared with someone who is sick, we will ensure good airflow is in the room, opening windows, using a fan. We must still maintain 6 feet between the beds if possible. It is best if they sleep head to toe, so as to separate the amount of air being circulated. If possible, it would be best to put a curtain around the bed or use a physical divider if it's a shared room. We must use a separate bathroom or one that can be disinfected after use. We have to always use PPE when encountering persons. And once again, temperature has to be checked at least twice per day. They are to be screened for respiratory symptoms and all other COVID-19 symptoms. Our facility must use best practices. When caring for residents who are in isolation or quarantine, staff will check the resident's general appearance every 4 hours. We have to check for temperature, oxygen saturation if possible, respiratory rate and breathing. We need to see if the respiratory rate of breathing is fast or labored. We have to see if they have symptoms consistent with COVID-19 to quickly detect deterioration. If so, they need to be transferred to a higher level of care. We have to reinforce hand hygiene. We have to always clean. We have to disinfect high-touched areas. Require face coverings and masks for staff. Use of additional PPE like gowns where appropriate. We have to assign dedicated staff when feasible, and always physically distance. After a resident recovers from COVID-19, a resident may have a residual cough, which can last days or weeks after any virus. The resident will wear a face covering when outside their room until the resolution of the cough and physically distance if in a communal setting. If they cannot tolerate or remember to keep the mask on, or physical distancing is not possible, they should wear a face shield and remain in quarantine for 10 days. After the resolution or of other symptoms or as directed by a resident's healthcare provider. Notify the resident's primary care provider and, if applicable, their authorized representative if the resident's conditions worsen or changes. Isolation. Any resident that tested positive for COVID-19, whether asymptomatic or symptomatic, must isolate. And any resident who was exposed to COVID-19 must quarantine. Those that must isolate or quarantine should not participate in communal dining. They are not allowed to have group activities or access to shared facility amenities or equipment until they have a negative test result, they have been cleared by the local health department, or they meet the above conditions related to isolation, time period, or improvement in the symptoms. For care of residents with an undiagnosed respiratory infection facility will ensure residents use eye, mouth, and nose protection and implement the following guidelines. They have to wash their hands or use hand sanitizer. There has to be a use of gloves, gowns or mask, eye protection, or face shield. Handling items in the resident's environment likely to have been contaminated with infectious body fluids in a manner to prevent transmission of infectious agents, meaning wearing gloves. Isolate heavily soiled equipment. Properly clean and disinfect or sterilize reusable equipment before use on another resident. We have to provide hand and respiratory hygiene and enforce cough etiquette by residents, visitors, and employees. We have to ensure employees clean their hands before and after contact with residents. Let me say that again. We have to ensure employees clean their hands before and after contact with residents. After contact with contaminated surfaces or equipment, and after removing PPE. In general, hand hygiene is done, this is very important, before, during, and after preparing food. Washing hands is done before eating food. Washing hands is done before and after caring for someone who is sick with vomiting or diarrhea. Washing hands is done before and after treating a cut or wound. Washing hands is done after using the toilet, changing diapers, or cleaning up a resident who has used the toilet. Washing hands is done after blowing the nose, coughing, or sneezing. Washing hands is done after touching an animal feed, or animal waste. Washing hands is done after handling pet food or pet treats. Washing hands is done after touching garbage. Facility will ensure tissues are available and sinks are well stocked with soap and paper towels at all times. Facility will minimize group and public activities. The facility will ensure residents are eating meals in their rooms, not a common dining setting, unless physical distancing is possible. The facility will attempt to create a staff contingency plan. The facility will prepare and maintain appropriate staffing levels by evaluating staff needs, keeping a minimum number of staff needed to provide care and a safe work environment. The facility will be in communication with local licensing office to identify and recruit additional staff when needed. If unable to provide adequate staffing, contact licensing. The facility will have signage and posting to explain facility implemented precautions for entering and exiting, deny visitors with any symptoms of respiratory illness, and deny entry to anybody who may have recently traveled within the past 14 days. We strongly encourage family members and friends not to visit and discuss alternative methods, such as texting, FaceTime, or calling. We have to establish specific visiting hours for limiting visitors to daytime hours when staff can be there to monitor the visitor's entrance. We have to isolate a resident that may have had contact with someone with a confirmed diagnosis of COVID-19. Isolation is for 14 days. We have to advise visitors to inform the facility if they develop any signs of COVID-19 within 14 days after visiting our facility. In preparation for any emergency situations during the COVID-19 pandemic, facility must implement the following recommendations. We have to be aware and engage in regional planning efforts to transfer residents with COVID-19 to designated facilities, isolation sites, or alternative care sites with adequate staffing. We must establish relationships with multiple facilities that may accommodate emergency transfers. We have to develop transfer agreements with other facilities, as well as reviewing existing emergency plans to modify to include infection control measures. We have to review resident and facility emergency information and ensure all information is current. Providing emergency preparedness training to staff, and ensure staff knows the facility emergency procedures. Preparing residents' medications and PPE to be transferred with the residents. Communicating with the accepting facility regarding space and staff availability. We must ensure proper transportation is available and ensure the facility accepting this patient has a designated area to receive the residents. Furthermore, we have to ensure all residents' medications, medical records are transferred along. Staff. If they are positive, asymptomatic, meaning not showing symptoms, they are only allowed to work in a designated COVID-19 unit. There must be a separate break room for staff assigned to different groups. If no separate break room is available, facility has a schedule in place to allow for cleaning of the break area between use by staff in different groups. Staffing plan is to limit transmission, including dedicated, consistent staffing teams assigned to the COVID-19 unit or wing. All efforts are to be made to have no crossing of staff between designated COVID-19 and clear zone negative residents. If staff must cross between designated COVID-19 unit and clear zone, they will be fully trained on appropriate use of PPE, donning, doffing between zones, and provide care moving from the clear zone to the red zone. We have to limit staff interactions to staff assigned to the same group. For asymptomatic staff who work at a facility with COVID-19 cases or who have had contact with residents who tested positive for COVID-19 in the past 3 months, they are not required to be retested as part of the surveillance testing, unless there was an exposure 3 months after the date of onset of prior infection. If symptomatic staff who work at the facility or have had contact with residents or other staff and who develop new symptoms consistent with COVID-19 during the 3 months after the date of initial symptom onset and no other alternative is identified as the cause of symptoms, retesting can be considered in consultation with the local health department. If testing cannot be done because of lack of testing availability, staff should be screened using alternatives: daily screening for fever, respiratory symptoms, and other COVID-19 symptoms. All staff who work at the facility or who have contact with residents or other staff who are asymptomatic and do not have known exposure should self-screen for fever, respiratory symptoms, or other symptoms of COVID-19 infection at home before leaving for work, and be screened at the start of each shift. For staff who test positive but are asymptomatic, these individuals will be instructed to care for themselves at home and not return to work until at least 10 days have passed since the date of the positive viral COVID-19 test. For staff who test positive for COVID-19 and have symptoms during their 10-day isolation period, they may only return to work once these following conditions are met. At least 72 hours have passed since recovery. There is a resolution of fever without the use of fever-reducing medications, and a resolution in respiratory symptoms. And at least 10 days have passed since symptoms first appeared. To ensure continuity of operations, it is advised that workers essential to operating the facility, basically the care staff and critical infrastructure staff, be permitted to work with residents who have COVID-19 following possible exposure, provided that the workers remain asymptomatic, wear an N95 respirator, wear gloves, practice consistent hand hygiene, and are screened for symptoms daily. Non-essential staff who are asymptomatic but were exposed to a person with COVID-19 should quarantine at home and return to work only when there's a negative COVID-19 test, when they are cleared by local health, or at least 14 days have passed since the most recent date of exposure. We have to reinforce hand hygiene, cleaning and disinfecting, high-touch areas, require face coverings, additional PPE, and when feasible, physical distancing. We have to clean and disinfect frequently touched objects and surfaces using a household cleaning spray or wipes. We must ensure employees clean their hands before and after contact with residents, after contact with contaminated surfaces or equipment, and after removing PPE. We've gone through this before, but I'm going to reiterate it again. Hand hygiene is done before, during, and after preparing food. Washing hands is done before eating food. Washing hands is done before and after caring for someone who is sick. Washing hands is done before and after treating a cut or wound. Washing hands is done after using the toilet. Washing hands is done after changing diapers or cleaning up a resident who has used the toilet. Washing hands is done after blowing the nose, coughing, or sneezing. Washing hands is done after touching an animal or animal waste. Washing hands is done after handling pet food or pet treats. And washing hands is done after touching garbage. The cleaning of surfaces with soap and water, then disinfecting with a household disinfectant prior to serving meals. We have to schedule activities with sufficient time to allow for cleaning and disinfect equipment, chairs, and other items. Once again, we have to reinforce washing hands, cleaning and disinfecting areas that are touched a lot. We have to require face coverings and the use of additional PPE where appropriate. Once again, physical distancing is of the utmost importance. Thank you very much, and we will move on to section 4.